Hello guys, this is Dr. Ignatius Cole and today I'm trying to make SOC easy for you guys who are studying for the USMLE exams. I'll assume here that you know the basics about SOC. If you have not read the basics, I suggest you to go look at your textbook and read something about SOC before you come here. And in this video, I'll try to help you answer the questions related to SOC that appears in the USMLE exams. So let's begin. So this is the dreaded table that I have seen in a lot of textbooks and even in UWorld. This table. You have to know this table by heart to answer the questions in the USMLE question banks and even in the exam itself. So I'll try to make this easy. I'll try to break it down for you. Now here we are learning about SOC, but we have to learn these. We have to learn 5 terms in total, and we have to consider these 3 terms at first. The central venous pressure or the right heart preload is the amount of pressure applied by the blood to the right atrium itself. So since the right atrium is connected directly to the venous system, it is connected to the inferior vena cava and the superior vena cava, and it is a valveless connection. So the pressure on the vein is directly transported to the right atrium. So the central venous pressure is the right heart preload, and pulmonary capillary wedge pressure is the pressure on the left atrium. So CVP is the right atrium and PCWP is to the left atrium. It is a pressure on the pulmonary capillaries. And another term we have to know is SPR, the systemic vascular resistance, is the resistance given by the arterioles into the system. So this is the arterial pressure. So you have to remember CVP, which is the right atrial pressure of the right heart preload, PCWP, which is the left atrial pressure of the SBR, which is the systemic vascular resistance. Now we have to consider this together. Now let's move on. Now we also have to consider 2 facts. Since SOC is a state of tissue hypoperfusion, we have to remember that cardiac output usually falls in SOC. Not always, but usually falls. And when cardiac output falls, mixed venous content also falls. So we have to consider cardiac output and SpO2 together. Now, to learn about our tips and tricks, we have to consider that CBP, PCWP, and SBR. CBP, PCWP, and SBR usually rise and fall together. These are the weird, complicated stuffs. And meanwhile, the easier stuffs are which contains the letter O, the SpO2, and the CO. It is actually SpO2, but to make it easier, I remember it by calling it SpO2. It's actually the venous oxygen content. So SpO2 and CO, cardiac output, will always rise and fall together. So when SpO2 decreases, cardiac output also decreases. When SpO2 increases, cardiac output also increases. And the CBP, PCWP, and SBR will usually rise and fall together, not always, but usually. And these two will move in the opposite direction. So when SpO2 and CO will fall, then CBP, PCWP, and SBR will rise. So distributive SOC is an oddball. We have to consider it as separate. Distributive SOC, the example of distributive SOC being septic SOC and anaphylactic SOC. Now let's see how the table turns out. Now at first we'll try to answer this. We have to consider cardiogenic SOC as a template of SOC. It is the basic SOC. It is the most basic, is the template of SOC. So in SOC, what we know is that the cardiac output will decrease. The cardiac output has to decrease because the tissue perfusion has to be low. And since it is a cardiogenic, is the heart does not pump enough blood, the CO will fall. And what we know is that CO and SbO2 will always, yeah, right, you told it right. So CO and SbO2 will always fall together. And when CO and SbO2 will fall together, the SBR or the afterload PCWP and CVP will rise. So these two will fall and these three will rise. They will go in the opposite direction. Let's see the table now. See? Now we have to fill this obstructive SOC or the tamponade. So in this also, the basic concept of SOC is that the tissue perfusion decreases, the cardiac output has to decrease. So in obstructive SOC or tamponade also, cardiac output and SpO2 decrease. And when CO and SbO2 decrease, then SBR, PCWP, and CVP, the weird stuff, will increase. So in obstructive SOC also, the same thing happens. Let's fill the table now. Right, you can see guys, so this is actually pretty easy. Now what we have learned is that the distributive SOC is the oddball. It contains anaphylactic and septic shock, and this is the oddball. So since this is the oddball, now let's fill up the cardiac output and SpO2. Now in this, even though the tissue perfusion has to fall, the cardiac output usually rises. So that is why septic shock is sometimes called warm shock. The peripheries are actually warm. So cardiac output has to rise, and since cardiac output and SpO2 will always go together, the CO and SpO2 both will increase, and meanwhile these three will go down because they go in the opposite direction. Now let's feel it. Right. Now look at this beautiful table, guys. We have filled it in a very wonderful way. We have compared these three the basic types of shock, cardiogenic shock being our template, and since cardiac output and SpO2 will always go together in cardiogenic shock, cardiac output decreases and SpO2 will also decreases, and the other three will rise. And similar happens in obstructive shock. For example, in cardiac tamponade also, we see the same changes. And meanwhile, distributive shock, which is the oddball, or anaphylactic and septic shock, the opposite will happen. It's a warm type of shock. The periphery will warm, so cardiac output has actually increased. So SbO2 will go in the same way and increase. And meanwhile, our CBP, PCWP, and SBR will decrease. Now let's move on. Now, in simplifying this concept, I omitted one type of sock. If you have noticed, I omitted hypovolemic sock because it doesn't. It actually follows our rule, but there is a little bit of change. We'll discuss hypovolemic shock later. Now I'll try to make this concept simpler. As I have told you, distributive shock is an oddball. Septic shock has to be considered separately. It is the only shock where the cardiac output rises, and along with cardiac output, the SbO2 will rise. And it is the only shock where SBR, or systemic vascular resistance, falls. Now let's move on. Now look at this distributive shock. It's kind of a oddball. You can see that it has gone in the opposite direction as to cardiogenic and obstructive shock. Distributive shock has gone opposite way. See? Now we have to feel this obstructive shock or the tamponade. So in this also, the basic concept of shock is that the tissue perfusion decreases, the cardiac output has to decrease. So in obstructive shock or tamponade also, okay, so let's hammer this concept home. SBR will always rise. This is the afterload. This is the resistance applied by the blood vessels. When the blood vessels know that the amount of blood in the body is less, or the cardiac output is less, where the tissues are getting less amount of blood, the resistance of the arterioles will always rise. There is always arterial constriction, except in, of course, a distributive shock. Now let's move on. Yep. Now, to add this a little bit, to make it a little bit more complicated, let's talk about hypovolemic shock. Now, in hypovolemic shock also, SBR rises because I've told you the vascular resistance rises in all type of shock. So SBR also rises here. And a cardiac output decreases in all type of shock. And along with cardiac output, this SbO2 will also decrease because they go together. But because there is no fluid in the body, this is an exception here. Preload falls. Preload to the right atrium falls. Preload to the left atrium falls. So CVP and PCWP will fall. Now let's fill the table. Right. Now we've talked about hypovolemic shock. SBR has to increase in all type of shock. So SBR increases, and cardiac output has to decrease in all type of shock. And along with cardiac output, SpO2 also decreases in all type of shock. But the exception for hypovolemic shock is that CBP and PCWP will decrease. Right, guys, so a bit more complicated here. Now, and that's done, guys. This is the table. This is the dreaded table you needed to remember. Always remember, CO and SpO2 will always go together. They will always fall. Remember, SBR will always increase, and usually CBP, PCWP, and SBR will go together and in the opposite direction of cardiac output. That means when cardiac output falls, this will go up. Remember that distributive shock, which includes anaphylactic and septic shock, is the exception to our rule, and this go this just in this distributive shock, cardiac output increase, and CVP, PCWP, and SBR will decrease. The hypovolemic shock has a bit of change to it. That's all, guys, for all of you. By this concept, if you remember this concept, you will get 90% question right. But those of you aiming for 270, 280 in step 1, I have to add a little bit more. Yep, and that's it. In obstructive soft exit tamponade, for example, right heart failure, pulmonary embolism, and tension pneumothorax, the PCWP is actually low because it's the pulmonary capillary waste pressure and it falls. For the sake of completeness, if you have remembered, if you have actually gotten all the concept I talked about previously correct, you have to just mark this little tinge. And with this, goodbye. I hope I made it easy. Please comment in the comment box below if this helped you. Thank you.